it was interesting because usual care in a lot of studies was the control, but yet
Correct.
usual care included things like advice or sometimes
Mhm.
soft tissue mobilization or sometimes nothing. And so Stephanie Pascoe and colleagues wrote a paper on the problem with the term usual care. And so maybe you could kind of elucidate for me. It sounds like maybe you're using usual care in this context as like what's typically done, and then
Correct.
maybe trying to figure out what are some other interventions. Can you kind of tell me a little bit more about how you're using usual care and what you're hoping
Yeah.
to find out?
Well, yeah, Amy, I think you're kind of speaking to the fundamental issue in even wanting to do this study. I had a conversation recently. Of course, I've been speaking back and forth with all the authors of the paper, and the premise is to have some consistency. Like, what is usual care? Like, if you've read a paper.
Hi, everyone. Welcome to the Aon Hands On, Hands Off podcast. This is Amy McDevitt. I brought a guest on today to talk about some different projects that she's working on and that I'm also working on in scholarship. We thought it might be kind of interesting just to have a little bit of a riff on scholarly work and what it means and what we're working on. And so, just to remind you, I'm at the University of Colorado. I'm an associate professor there teaching musculoskeletal courses. I'm involved with some clinical and educational research. And then I also work clinically in our hospital based system. And so I'd like to have my colleague introduce herself next.
Yes, of course. Hi, Amy. So good to be here with you. So my name is Moyo Tillery. I am an assistant professor at Tufts University in our Boston campus. I'm also the director of admissions at Tufts Boston, so wearing a couple hats, geographically located in North Carolina, but affiliated with the Boston campus. So really excited to be here and have this conversation.
Awesome. And I have a place in my heart for you because we kind of became friends. It was like serendipitous. We just
Yes,
met at a conference. I think it was either last year or maybe it was the year before. I think it was the year before.
two
Is that
years
right?
ago. Yeah,
Yeah. And we were at some kind of reception and just started talking and just hit it off. And
yeah,
now we're friends and colleagues. And I love when relationships start like that. And that's, I think, another reason why the AMT organization has just been instrumental for me personally.
totally
Um,
agree.
yeah. So, well, I would love to hear a little bit about some of the scholarship that you're working on. I mean, many of us in academics have to have some kind of a scholarly agenda, and hopefully it aligns with something we're interested in, but not always.
Yeah.
So, tell me a little bit about one of the projects that we were talking about offline that you're working on.
Yeah, no, thank you, Amy. I think I will say, especially as like a new academician, scholarship, I think those of us who transition to academia from the clinic, that's probably our biggest gap to fill in learning how to do research,
Yeah.
particularly without, a PhD or an EDD or some other form of doctorate. But to answer your question, Amy, I am fortunate because I work with very collaborative individuals at Tufts. And so this first study is, a collaboration with my colleague, Audrey Elias and Jake Mishke and Josh Cleland. And it's a scoping review, looking at control and comparator interventions for plantar heel pain.
Okay.
So this is a study that I think when you hear the title, it's very specific, but when you kind of take a step back, the central concept is that there's a lot of variation in studies that claim to look at something, right? But it's defined and described very differently once you get into the papers.
Yeah.
And, even in AOMT, we talk about the word manual therapy and taxonomy and having a common taxonomy. When we look at what is manual therapy, how do you define it? How do I define it? So this is one of those studies that I think gets at that. I think the research question, the goal is really to understand the types of interventions that are considered usual care. And I say usual care in quotes because it is defined different ways. And these are clinical trials. Like, how are we defining what is usual care?
Yeah.
Um, and then, of course, I think the other part is defining it, but how consistent are we in the definition of usual care for heel pain? And so our goal is to pull studies and see which studies have and of course, these interventions are biased towards interventions that are within the scope of physical therapy practice.
Okay.
So we're excluding studies that maybe don't fall into that category, and then kind of digging down to see if beyond which interventions are considered usual care and how are they consistently described, just to see if there are any trends in the way it's applied based on like the study design or
Yeah.
other factors that we pull from our papers. So it's really, I'm really interested in, we're early in the stage, we're screening abstracts right now, and it's really going to be an interesting study, and I think a springboard for maybe looking at some common interventions that we've just kind of bunched into usual care and never really drilled down to define it. So yeah, that's kind of the first project, Amy.
So in terms of, I have a question in terms of usual care, because this is a really interesting topic. When I did a systematic review with Derek Cooley and a few other people a couple of years ago, it was interesting because usual care in a lot of studies was the control, but yet
Correct.
usual care included things like advice or sometimes
Mhm.
soft tissue mobilization or sometimes nothing. And so Stephanie Pascoe and colleagues wrote a paper on the problem with the term usual care. And so maybe you could kind of elucidate for me. It sounds like maybe you're using usual care in this context as like what's typically done, and then
Correct.
maybe trying to figure out what are some other interventions. Can you kind of tell me a little bit more about how you're using usual care and what you're hoping to
Yeah.
to find out?
Well, yeah, Amy, I think you're kind of speaking to the fundamental issue in even wanting to do this study. I had a conversation recently. Of course, I've been speaking back and forth with all the authors of the paper, and the premise is to have some consistency. Like, what is usual care? Like, if you've read a paper or two or 300, you've seen it, and Amy, you and I both know that patient education is a powerful tool. Manual
Yeah,
therapists rely heavily on it, ironically, right? Because we're, sort of thought to be so hands-on, which we are. But there's power behind patient education, but that looks very different from the next person's usual care, which could just be a home exercise program or nothing, right? And
yeah,
so for us, we want to think about clinical application of whatever the outcome of this paper is, and nothing is not an option, right? Like, that's not a criteria we're exploring because we're going to intervene. It's just a matter of what are we defining as our standard of practice and care versus maybe more specialized care for the same condition. So to your point and your question, I think it's just being a little more clear and a little more specific, without losing clinical application of what we can do for patients with heel pain. So I
yeah.
think that's what we're getting at.
Yeah, I think that's great. And hopefully this, what Derek Cooley, for example, and I talked about in a recent podcast was, clinical practice guidelines are fantastic and they offer so much and they afford, us frameworks and up-to-date information, but they become outdated very quickly. So what I'm excited about in terms of what you're working on is it's almost like a mini update in terms of some of the care surrounding individuals with plantar heel pain. At least that's what it sounds like to me.
Yeah, that's exactly right. I mean, it's, like I said, I referred to it as a springboard because I think we're gonna discover a couple different things that already exist. It's just how do we package it up a little bit more nicer, almost like a mini CPG, right? I love that
Yeah.
analogy, and I
Yeah.
teach the CPGs. That's how my students need a framework at the entry level for addressing heel pain and lower extremity pain. And so our CPGs are crucial for that. But of course, we have students in the clinic now who will ask, like, thank you for the CPG, but,
Yeah. But now what?
but now what? Yeah. So,
That's right. So have you seen any I know you said you're only in the abstract review phase, so you may not have this information yet, but anything interesting that you've seen as you're kind of going through abstracts that maybe is something that wasn't included in the practice guideline? Like, are there any interventions that you weren't expecting to see?
I think honestly, Amy, I think that something that, and I kind of chatted about this with Audrey as well recently, is I'm seeing a lot of, and it shouldn't be surprising, I'm seeing a lot about orthotics, which I know the CPGs
Yeah,
do cover, but it's
yeah.
interesting because I don't think that we're getting a ton of information about, type of orthotic. It's just not, I'm seeing a lot of studies that really compare a certain orthotic type with another orthotic type,
Oh, interesting.
with another orthotic type with exercise versus with, I mean, it's just like orthotics here and there, which, I think you talk to different people and their theory about orthotics varies so greatly. So I'm actually curious to see if, there's something here because patients do like tangible things that they can, like, I'm going to go to the store and buy
Yep.
this, and sometimes that's not ideal, but if it's gonna, is there some benefit to a certain type of orthotic? I mean, we might see that in the study that we maybe necessarily weren't looking for. So I thought that was interesting. I wasn't really sure, it's within our scope, but is it an intervention? Is it not?
Yeah.
So.
Well, that's interesting because, I think there's some, I love how research has evolved and in the, how many years have I been practicing? 20, 26, but more in academics 14. So I guess I would say that I've really only been paying attention on a more granular level since I've been in academics. But it's
Sure.
interesting that, earlier in my career, it was like this manual therapy intervention versus this one, or this exercise versus this one. And then we got over it and we're like, okay,
Mhm.
it's just manual therapy in general, plus exercise is, more optimal. So that multimodal approach. And then, I think in things like plantar heel pain and plantar fasciitis, it was decided that yes, orthotics, but it's
Mhm.
interesting that you're kind of seeing that now we're kind of back to this one versus that one. But maybe
Correct.
they're missing something.
Correct, correct. I mean, to your point about the evolution of research, it's like, do you need to revisit some things, right? Is it maybe the quality of research study, maybe the quality has changed,
Yeah.
from, and is it okay to redo a study from the past? I know we're going to talk about this later, but in thinking about educational research and like things more abstract, like professional behaviors and PT students, and like, do we need to redo a study that created an outcome measure from 30 years ago that we use to measure something now because things have changed. So I
Yeah.
mean, this is obviously still the orthotics thing is not a focus of the study, but I'm really curious about if that has some kind of a, if it shifts something that we had kind of prescribed
Yeah.
previously, whether in a
Yeah.
CPG or not. Yeah.
And
So.
I think what's cool about being on a team for either a scoping review or a systematic review is, really one of the limitations is you take all these randomized controlled trials, or recently I worked on an umbrella review, and so we were looking at
Mm.
tons of systematic reviews. The recommendations that you put out as an authorship team tend to be very general because
Mhm.
research is so heterogeneous, whether it's all the RCTs and all the systematic reviews. But what's interesting is you learn a ton as an author because you're really having to comb through all of this and you just learn a ton about a topic. And I
Right.
really enjoy that part of the process. So even though
Yeah.
the recommendations are a little bit scant in terms of detail, it's only because of how heterogeneous the work is that you're looking at.
Yeah.
I think you get to learn a lot, and so you're
Yeah.
gonna you're gonna soon be a plantar heel pain specialist, whether you want to be or not. Even if you probably already are, but you're gonna be even more so.
Even more so, yeah. No, that's great. I totally agree with you, Amy. I couldn't really add on to that. Yeah, so I know you're busy and you're always doing things, Amy. So please tell me a little bit about what you've been up to as well. What's going on in your world?
In my research world.
Yeah.
If I talk about that, I we just talked about something that made me think about how research is kind of evolving. I think early in my career, I was working on a lot of randomized controlled trials, looking at manual therapy versus exercise, and that's for people with we did a study, gosh, back in 2012 or 11 or 13 or something. It was myself and Julie Whitman and Josh Cleland, Paul Minkin. We were looking at inversions, people with inversion sprains, and doing manipulation versus exercise. And I think back then, 15 years ago, that was very popular. And so the study I'm just finishing up now is is interesting because the intervention is still manual therapy versus exercise for individuals with chronic neck pain, but
Mhm.
the outcomes we're looking at are different. So the outcomes aren't which one is better. The study I'm just finishing up with Chad Cook and Brian O'Halloran and Derek Cooley is looking at specific and shared mechanisms. And so I guess what that means is, we know that there's specific things that happen. If you think of like the Bialowski and colleagues,
Sure.
their famous figure that it's like, okay, here's your mechanical stimulus and here's all the
Mhm.
things that happen. We're trying to figure out how much of our outcomes might be driven by the specific mechanisms of manual therapy, the specific mechanisms of exercise,
Mhm.
and then how much of that is actually driven by other things that we may not maybe give enough credence to, like
Mhm.
the therapeutic relationship, the partnership, the environment, the clinician equipoise, the patient expectation. So I'm really now interested in
Mhm.
that because you're a clinician too. We know it matters.
Mhm. Mhm. I agree, Amy, and, when I'm speaking about, like, some of the things that feel a little more abstract, I feel like you're hitting the nail on the head. There's this gap of there's a whole lot in between the
Yeah.
mechanisms that we've learned as manual therapists and fellows, and, there's biopsychosocial, but where we forgot about the psychosocial part. Sometimes it feels like, is it Amy treating the same patient the same way? Maybe there's a force table under the, a force table on force plate under the table, and you and I apply the same force as same patient, and for some reason they get better with you than me. What just happened? Like, there's a gap there, and I don't know what that is. And so it's
Yeah.
really exciting to think about maybe what you'll uncover there, and how we can use that to guide our treatment. Are you seeing any, just as you've done this work, Amy, are you finding things that maybe you didn't expect to find so far,
Yeah,
or anything
I mean,
surprising?
that's a great question. I mean, one of we did look at some preliminary data already, and we haven't done a full analysis because long-term outcomes we're looking at 6 months. But what we are finding is it may not actually matter which intervention
Mm,
you're using, manual therapy or exercise. And I think we've all been taught that multimodal is probably better anyway. But what's interesting is we're kind of maxing out some of our tools. And so
mm,
what I mean by that is when we're looking at things like therapeutic alliance and a work alliance inventory, which is one of the tools that we're using. This is going to sound like I'm bragging on PT, but we're almost too good. And
mm,
what I mean by that is if we're doing our job and we're being human and we're being authentic and we're putting the patient in the center, we're kind of maxing out on some of these tools, meaning the patients trust us,
yeah.
they believe in us, they believe that we're listening. And I think that's why some of the tools that we chose in this study might not actually measure what we want to measure because
Mm,
we're kind of hitting a ceiling effect with some of the tools. And I think it's a
yeah.
good problem to have.
Sure.
But in
I
a
love
next study, we're going to look at using tools that might be a little bit more sensitive to what we're trying to measure.
Amy, I love to hear that so much. And I'm listening to that with a lot of bias because, I teach a semester one professional expectations course where you're really introducing DPT students to professionalism. Like, what is
Yeah.
it? And of course, at the corner of that is patient centered care and the therapeutic alliance. And sometimes I think, if we all think back to when we were in our first semester, we're like, there's not a lot of meaning to that when it comes to like driving patient outcomes. So it's really nice to hear you say, this is evidence supported. Like, we've been telling you that it drives outcomes if you take the time initially to build your therapeutic alliance. And I think other part of what I think I'm hearing too is, and this is something that during fellowship training was really emphasized, is even choosing the right patient for the right intervention. Like, it's not, at the end of the day, you're a diagnostician. Is it the intervention? Is it your ability to diagnose and pick the right patient for the right intervention? And that match is so important.
Yeah.
So I just love to hear that there are even more dimensions to matching the patient to the intervention. Then there's all these other factors in between that could drive
Yeah.
outcomes.
I totally agree. And I think it's neat that you get to teach that in the context of an entry level program in a course. I mean, what you're describing is precision medicine, which is we're trying to get closer to not just, blanket take a CPG and say, oh,
Right.
this one recommends this, this, and this. Everyone that has this particular health condition is going to get that.
Right.
Where we're really trying to get, I think, to be patient centered is precision, which is like this patient that has this particular type of cancerous tumor needs this type of chemotherapy drug. You don't just give everybody
Right.
the same drug and hope for, a good outcome. It's precise, but we're not there yet in PT, but we're
Right.
trying. And I think what I'm also optimistic about, Mo, is that like we we put a lot of time, effort, and energy into teaching psychomotor skills and exercise,
Mhm.
and all of it is important. But I'm hoping this work guides us a little bit more on maybe where we need to spend equal effort in terms of
Yes.
educating in entry level residency fellowship.
Yeah.
Because if that relationship matters more, or at least matters as much, then we need to make sure we're fostering that skill set too.
I totally agree. Totally agree. What a nice bridge between the world of manual therapy and like PT education. Sometimes
Oh,
I think there's a gap, but there it is. You filled the
I'm
gap.
excited. So hopefully
Yeah.
we have something that comes of that in terms of not just clinical, improving our ability to treat as clinicians, but to,
Yeah.
in terms of education. And so I'm going to kind of pivot to another topic because you had told me that you're also working on a retrospective cohort study, which I thought sounded interesting. So do you want to tell us a little bit about what that study is all about and where
I
you are in that process?
Sure. No, thank you for asking. That's a little bit of a pivot from the heel pain study, but this is a study. So, a little my clinical background is in occupational health. So
Oh,
to define that a little further,
yeah, okay,
I
please
think
do.
what most folks are familiar with is that work comp patient that comes to the clinic.
Mhm.
But working at Concentra Medical Center for over a decade now, it's where it's essentially an incredible early intervention model that really fits with a lot of why manual therapy is effective. And working in this space has kind of really driven my love for manual therapy and pursuit of it, because those patients really did respond well.
Okay.
So basically, injured workers, big picture summary of the study is, a lot of Concentra's work is toward that population, but employer services is also part of that. So Concentra service serves a lot of municipalities. So when you think about like the city of Boston, or that's what I mean by municipality, and those folks do send their tactical workers to those occupational health facilities like Concentra. So your injured police officers, your firemen, kind of folks that have really physical jobs and are prone to injury just by nature of the work.
Yeah.
So I always found it interesting because those patients kind of tended to make up the bulk of our more severe cases. And those injuries tend to be more on the severe side. So I'm kind of the goal of the study is to kind of take a step back and examine like how prevalent some of these injuries are within just those populations, those characteristics of those injuries, and then even the distribution of the types of musculoskeletal injuries we're seeing in fire. So, for example, are the firemen having more shoulder injuries because they're fighting a hose, or are firemen having lower quarter injuries because they're having to chase an assailant. So different things like that. I'm really interested in breaking that down a little further. Some of the other things that I'm hoping to look at with this study is, risk of injury. So that has implications, as you know, on the front end with prevention. If there are certain factors that predispose certain folks to certain injuries, it would be nice to characterize that. And then honestly, on the back end is, the hope is that findings from this study, and we're going to look at different regions. Concentra is a national company, and so we're partnering to look at different regions and different municipalities and see if there are potential to create almost like an injury prevention program that's specific
Yeah.
for tactical workers in municipalities. This is something that I think would be crucial for another part of some of the things I want to look at in the study, which is like lost work time, disability, kind of more of the financial implications and life influence that can come from having a work injury. So lots to look at. I think
Yeah.
there's some fine tuning. This is still early in the works. We're working on the IRB. But yeah, that's something else I've got going on right now, Amy.
And I think it's very relevant. I mean, for a lot of reasons, right? I think as clinicians and researchers, it gives us information about certain populations because we're always trying to learn about certain populations. And then there's this fiscal component to it, right? So if your findings come up with something specific, I would imagine at the state or municipality level, it's motivating to invest in programs that might decrease their risk or
Correct.
programs that are effective. It kind of reminds me of Richard Westrick, who's a PT who is a military researcher. He did some work looking at cadets in the army, and what was interesting about his work is they were starting to see kind of a shift in who's actually enlisting in the military, and so
Uh,
they really looked across populations of military, and they looked at things like BMI and smoking habits and all sorts of factors to better kind of predict risk and
risk,
injury.
yeah,
And I just found it really interesting. And part of why they did it is the demographic of people that were enlisting in the military has actually changed drastically,
mhm,
in 20 to 30 years for all sorts of reasons. But I just felt like what a productive thing to do is to look at actually who's at higher risk and kind of
right,
like prognosticate that. And that's kind of what you're doing, which is like who's at higher risk? Is it based on maybe individual characteristics, or is it
right,
based on actual occupational responsibilities and work?
yeah. I mean, I think that that's exactly right, Amy. That's what we're getting at. And you refer to it as precision medicine. And I love that because, again, we're trying to drill down to, there's these two populations, but what about them? We currently we will direct the treatment pretty early to just treat the intervention. I mean, treat the impairments, right? That's kind
Yeah,
of, you can't go wrong if you treat the impairments. It's patient centered approach. But hopefully, we will, to your point, uncover some other things that maybe we could emphasize, like social factors or, to your point, where are we recruiting these tactical workers and
yeah,
geographically what's happening in these places, environmental factors maybe that are influencing. Is it heat? Is it temperature, right? Are we looking at tactical workers in the South? Do they tend to get hurt in the summer? And things like that. Those are trends that I know clinically I observe just, you know, anecdotally, but I've never been able to put my finger on it and say police officers tend to get more shoulder injuries in the winter, when they're, having to jump a fence. Like, that's pretty precise, but I'm really excited about the study because I've worked in this space for so long. So,
oh, is that cool? And I love something you just said, and I don't know that people believe this, but a lot of times I think in terms of research, we're trying to answer questions that were observations that we made sometimes for many years clinically. And one of my questions was always like, why do certain patients get better and others don't? And maybe it is this contextual piece. And in your
mm,
environment, you're seeing patterns, but you want to kind of describe the pattern in a more sophisticated way. And I love that you're taking something that you've observed and now turning it into, scholarship that's going to result in some, I imagine, very meaningful recommendations and conclusions.
yeah, certainly hope so. I mean, I'm super grateful to Concentra for allowing this partnership and, hopefully we'll put out something cool and keep putting out more cool things,
Yeah.
in
Yeah.
this world. So, yeah.
So then on more of an academic side, what are some of your observations coming from being in academics, and do you have any educational scholarship that you're working on, kind of on the academic side based on some things that you've seen or observed or been privy to?
Yeah. Amy, I think this goes back to, figuring out academia as a clinician, and understanding, I have really great mentorship where I am, and one of the things that I was told is make your day in and day out your duties? Can you make scholarship out of what you're already doing? And
Kind of
so for me, yes, exactly. Like there's only so many hours a day, and you need to put out what you need to put out. And that was great advice. Thank you, Craig. And so with that, there's some there. I did some contributing of data, admissions related data, with my team at Tufts in Phoenix and Seattle. And so my colleagues are leading a study that we're looking at like the influence of the GRE
harder.
in admissions, kind of revisiting again. We're talking about the cyclic nature of research, is
Yeah.
revisiting that shift. And so there's that. And then there's another study, also admissions related, where we're trying to tease out components of the applicants and their application that could tell us things about their characteristics like grit and resilience outside of just saying, I am resilient. What can we characterize that?
Yeah.
Um, and this is of particular importance, I think, in any PT program, but it's a hybrid accelerated model. And so you've got challenges related to being in a graduate program, and then an accelerated program. So that's kind of why we were interested in those pieces. So contributing data there, and then we're super excited to have a two-part study related to the experiences of minority faculty.
Mhm.
Um, the part one was kind of entry into the profession, and the part two was the faculty piece, so entering academia and the academia experience with minority faculty. And that was with my colleague Carla Sabis is the lead on that study, and we partnered up to um, we found some interesting themes there in that study. And obviously, being a minority person in physical therapy, it was interesting to kind of share some experiences with our participants and be able to kind of formulate a theme or a couple of different themes based on our study findings. So those things are happening sort of
Yeah.
on the other side of my scholarship.
And so the last thing you spoke of, is that in press yet, or are you still kind of analyzing like qualitative data or?
We are done. It's recently, I think part two was this week, going into press. And then I think it was February or maybe a little bit after that, where
Yeah,
part one was accepted. So really looking forward
that's
to seeing
awesome.
that
That's
study out.
awesome.
Yeah.
And I guess what I would say, based on some of the things that you talked about, is for people that are early in like some kind of an academic career, or if you're faculty in a residency or fellowship, working smarter, not harder is primary. I think having a mentor goes without saying, but I would
Yeah.
also say, pick something that like lights you up, like blows your hair back. Don't just pick something because there's some obscure gap that you've recognized.
Right.
But I just feel like, especially if, being having gone through a PhD program and you're working on something for like 6 years and you kind of get tired, but it really matters to pick something that you either have some lived experience with,
Hmm.
that you're working on, like hearing that you're involved with admissions. It does make a lot of sense to pick something that kind of pairs with something that you're working on
Yeah.
anyway, or something that you're passionate about.
Totally agree. That was great advice. I mean, it was advice that I got day one, maybe
Yeah.
day five, and just took it and ran with it. So thankful for that mentorship. But yeah, so Amy, what else are you up to? Because I know there's more. There's always more with you. You're so busy. I don't know how you do it.
We're all busy though. We're all busy, you
This
know?
is
I try really hard not to use the word busy when people are like, "Oh, how are you?" I'm busy. Well,
true.
everybody. And I think part of it, I've learned about myself that I'm not happy and thriving unless I have a certain amount of work that's on my plate to keep my
Totally
interest,
agree.
you know. But speaking to the topic we just talked about, at the University of Colorado, I chair the curriculum. So I direct the curriculum for our hybrid and residential pathways. And we are going to be moving towards adopting some of the tenets of the competency based education framework, which was recently released, but our work has been ongoing.
Yeah.
And so right now, it's a really fun project. I'm pairing up, or our program is pairing up with three other institutions. And we're basically going to be sharing our different models of
Mm,
slowly integrating some of the more meaningful, I think, tenets of competency based
right.
education into our curricula. And so We have a session at CSM, which will be coming up, and then we're working on a paper because, not everyone agrees with competency-based education. I've personally learned a ton about it, and I feel quite knowledgeable in that space, and I see a lot of positives, but it doesn't mean that everyone has to, it's not an all or nothing. It's not like binary,
Sure.
like, yes, you're doing it or no, you're not. There's so many elements that I think you can draw from that model that can be integrated into entry level curricula or residency or
Mhm.
fellowship. And I know there's a lot of working groups, both in AOMT and in the
Mhm.
Orthopedic Academy, for example, because that's our kind of shared world, that are working on this. But I'm excited about it because I think it from our standpoint, what we've always struggled with is like, what is entry level? Like, where
Yeah.
is it? What is it?
Yeah.
And like, what are some of the things that a student going into their first clinical, for example, what should all students share?
Mhm.
And I think, you probably have similar experiences, but when I was a clinical instructor, it's a crapshoot. Like, you don't know what
Mhm.
you're getting because everybody is so different,
Yeah.
and curricula are
Even within the same program.
even within the same program, you
Mhm.
don't know what you're getting. And I think what kind of sold competency based education for me was learning more about how it has high utility in medicine.
Mhm.
Veterinary medicine has some of the best fully fleshed out standards in terms of competency based education and EPAs and milestones. And it's
Mhm.
fantastic, and it's all public. Like, you can look at their kind of website and just see how it's
Wow.
designed. And it's like, I think I'm pretty sure I know what every veterinarian in the United States does, but I can't tell you what every PT in the United States does because
Mhm.
we're
It's
coming from such
different.
different backgrounds, but it
Yeah.
shouldn't be that way. And
Yeah.
so, I'm being probably too verbose here, but I've learned a lot about competency based education, and so that's a project that I'm working on. And then, I've had some other little projects. This year, I teamed up with I don't know if you know Jeremy Lewis and Paul
Oh, yeah.
Minkin, but we were just shooting the breeze at a conference, after hours and talking about things that we were passionate about as clinicians. And so the three of us got together and decided, okay, for each one of us, let's pick our passion,
Mm.
and the three of us are going to write about it together. And so we
Mhm.
published two of the three of our passions, and mine is the last to come out. And so,
Wow.
it's been really fun, to do something like that where it's just a little bit of a pet project, but they're all in the form of viewpoints. One of them, is in JOSPT right now. It's called "The Worst Pain is an Unexplained Pain," and that really talks
Mm.
about using patient centered language and maybe even the clinical practice guideline recommended language with patients. Um, and
Love
then
that.
yeah, it was a fun project. And then the other one was in JMMT, and it's called manual therapy with a bit of exercise. Are you kidding me? It's time to evolve again. And Jeremy's passion is really about like health and wellness and
Mhm.
where people exist in their communities. What's their population like? We need to be better advocates at helping identify how to get people further with some of those other needs that we know influence their outcomes. It's not just
Mhm.
manual therapy, exercise, education. It's like, where do you live? Where do you work?
Gosh,
What
yeah.
are your struggles in your life? And so that paper really kind of fleshed out all the other things that we need to be advocating for. And then the third paper, I'm not going to disclose. So you'll we'll
Oh, no.
my
You're
passion
gonna leave
paper.
us hanging. I
I'm
was
gonna hang.
literally on the edge of my seat.
Oh
I was
yeah.
ready. I was ready.
So that'll come out. We got to. I have to kind of finish up that draft, and we'll be working on that. So we each got to pick a passion paper, and it was really kind of a fun, non-traditional way to get together with some friends, and write about things that you love. It was great.
I love that, Amy. I feel like this is the medicine for burnout, like,
Really?
sometimes students are like, "Oh, I keep hearing about burnout." I'm like, "You gotta remember your purpose, your passion, keep
Yeah.
following it. It's gonna look different in different phases." I
Yeah.
love that you've collaborated with a passion project with
Yeah.
these fantastic humans.
It's
That's awesome.
medical narrative, because
Yeah,
when we're working on things like your projects, the retrospective cohort study, and then the scoping review, we have to follow guidelines and parameters. But
sure.
to truly be able to express ourselves and really what we're passionate about, is really fun. And so as we kind of wrap up, I'm going to ask you and put you on the spot. If
Uh-oh.
you had a passion project, like if you got to write about something that you're passionate about within the field, toss me a
Mm.
few ideas of what it would be. And maybe you've already done it, or maybe you're already working on it.
Oh, that's a good one. Okay, let's see. So if I could pick a passion project within PT, Amy, I'm afraid it would probably be on the service end.
Okay.
And I've thought about this for many, many moons. I really have always been concerned about the applicant pool into the profession. I think a lot of what you're saying, um, PT is a new profession when we think about the rest of the medical professions. And I think we've spent the first couple decades proving our worth to patients and insurance companies. And we're missing our, I think we could do better immersing ourselves in our communities. I think there are lots of underserved areas that different amazing organizations are trying to target. My passion project would be to figure out a way to diversify our applicant pool to the profession. Because then you're getting people from places that do consider the environmental
Yes.
factors that drive outcomes because they're living it. I think it's all tied to lived experiences. So a mouthful, but I would try to figure out a way to do better bringing different types of people into the profession. I think we're doing better, but we have still a ton of work to do. So there's
Yeah.
that.
I like it. And if I had to, build on that and come up with my passion project, I think something I talk about with students all the time is, you know, students believe that it's all about like coming up with the right exercise and having tons of practice with thrust or non-thrust skills.
Mhm.
And maybe I'm saying this because I work in a hospital-based system, so I have the privilege of interacting with people from
Yeah.
all walks of life, from all
Yeah.
different communities that I would never interact with.
Mm.
And I want to continue to try to deliver the message that
Mm.
interacting with humans is that's the skill
I agree.
that really matters, like validating people and seeing them
Mm.
and hearing their stories, because we're one of the few professions that sits down and talks to people. And other than things like psychology and other
Yeah.
social work, and those are very important too, but with very different goals.
Sure. I
But
love that.
we both know it because we walk the clinical practice world and the talk and all that stuff, but it's like we're with humans,
Mm.
and we really need to somehow not lose sight of that skill set and what it means to try to connect with people.
I love it. I mean, I think if you asked my students, they would say, I always talk about the human connection, and that's storytelling and the human connection.
Okay.
That's what it's all about. So I love that, Amy. We
It
should
is.
do it together.
I was just going to say, I
The
think
birth of a new study
I
or
we might
project.
have a passion project that we're kind of, because I'm trying to parallel your passion project with what I'm thinking about, and I think there's an
Mhm.
intersection here.
I
So
agree.
we might have
We
to get back on Zoom or something and flush this out.
Stay tuned, everybody.
Stay tuned. But
Uh,
anyway, I guess in conclusion, it was so fun to just kind of get you on the get you on the horn here and riff a little bit and just hear about what you're working on. And we haven't been able to catch up in a little while. We usually catch up in
no,
person once a year, but this was a treat.
I know. This was great. Thank you so much. Love
Yeah.
it.
Yep. I know for sure I have a date with you in
In
October,
November. Yes,
November at our
I will
conference
see you
in
there. I will be there.
Reno. All
Can't
right.
wait.
Sounds good. I'll see you
Thanks,
then.
Amy.
Thank you so
Great to
much.
see you.
You too.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMT. Subscribe now so you never miss an episode, and connect with us at aomt.org or at AOMT on social. Opinions are those of the guests and not official AOMT policy. See you next time.